Farah?
Yeah, we will control it for you because we are sharing it. Yeah.
All right, okay. So good morning, everyone. I'm really delighted to be invited to this event, and I'll be sharing with you about the management of Bpsd. Bpsd stands for Behavior and Psychological Symptom of Dementia. I'll be focusing on the etiology, on the definition, prevalence, etiology, and a little bit of theory. And at the end of my talk, I'll be discussing about the impact of the behavior and psychological problem among people with dementia towards the caregivers. All right, next slide, please. This is the breakdown of my talk. Next, please. Okay. People with dementia. This is the extract from a journal in Germany. I'm really sorry. I could not pronounce the sentence on top of it because I couldn't speak in German. But anyway, it is about a lady called Ptsd.
Yeah.
Hello.
Last week was detected positive the PCR test.
Hello. Hello. Yeah. Yeah. So this is this lady is 51 years old, admitted to the hospital in Germany, and she had a presentation of cognitive impairment, and at the same time she had a strong jealous towards her husband, and she was quite distraught with this, and said that people tried to harm her, tried to kill her, and she behaved and quite aggressively in the ward. So the first presentation has been reported in this journal in 1907 by Dr. Alzheimer Lewis, which is on the right side. He is the one who coined the word for Alzheimer dementia that we use nowadays. So the presentation of this lady is the first documented of a person with dementia, with cognitive impairment, and with presentation of behavior and psychological symptoms. Next slide, please. So it is, when we talk about dementia, nowadays DSM-5 call it as major neurocognitive disorder, major NCD, but we like the term of dementia. So we still use the word dementia in our practice. Nowadays Bpsd has been called NPS, neuropsychiatric symptoms, NPS of dementia. When we talk about dementia, we are not talking only about memory. It's also, we are talking about the person as a whole. The person as a whole, they have problem also with their personality, change in their personality, change in their mood, change in their physical activities, change in changes in the perception, and also change in their function as well. So the patient as a whole, when they develop dementia, either it is mild stage, moderate, or advanced stage, they will go through a series of events that causing changes in their behavior. The family members or the loved one, people who are very close to them, they notice there's some changes in the person who having dementia. Probably it might start with memory, or sometimes it might start with physical problem, or sometimes it might start with some emotional problem. So it is a range of symptoms that the patient might present to us. It's not only a memory. It's not only memory. Okay, next slide, please. Oh yeah. So people who are experiencing Bpsd, they might cause distraught to the patient, and it might cause burden to the carers as well. So when the emergence of Bpsd, it might contribute to the disability of people who already have problem with their memory. So they contribute to the disability, and the person who are having Bpsd on top of their memory problem, deteriorate or progressing much more quicker than the patient who only has a memory issue. And then this causes distress to the family members. Family members might bring this the patient to the hospital, or sometimes they might require hospitalization or institutionalization, and this will increase the cost of care for the patient in the hospital, or sometimes it can cause work-related issue. The patient might cause problem in the hospital or in the institution or in the nursing home. Okay, so 50 to 90% of family of the caregivers, CGs for caregivers, experience physical aggression, which initiate or trigger the family members to bring the patient to the hospital or to the institution. This is the usual or the common presentation that I encounter in my clinic. Usually, if the patient only have problem with the memory, sometimes the family members can tolerate. However, when the person who having experienced dementia, when they presented with aggression, irritability, agitation, or other behavior symptoms such as sleep problem, the family might bring this to the hospital for consultation, or even for hospitalization. So frontline staff of the LTC, or LTC stands for long-term care, such as in nursing home, they experience physical assault by the patient who having a memory problem, who are having dementia. Okay, and this might significantly cause suffering to the caregivers and also to the dementia people with dementia. Okay, next slide, please. Yeah, according to the criteria by ADRDA actually, ADRDA and NINCDS. It's a bit long, but it stands for Alzheimer's disease related disorder association, National Institute of Neurological and Communicative Disorder, and stroke. It's a bit long. It can be a tongue twister for me also. But this is the criteria which is in the ADRDA and NINCDS criteria. So the patient having disturbance of affect and of one of the following, either they're experiencing depression, anxiety, irritability, or euphoria. One of the following. Or they might have associated symptoms such as physical problem, aggression, agitation, psychomotor agitation, or perceptual changes, hallucination, delusion, sleep disturbances, appetite problem. So all this, either one of the symptoms which occurring for the past 2 weeks, and it occur within 2 years of the diagnosis of dementia, so we can call it as a Bpsd. So it is a wide range of symptoms from anxiety, depression, to the psychotic symptoms such as hallucination and delusion, even paranoia as well. So it is wide range or spectrum of behavior or psychological issue that the patient might experience. Next, please. So it occurs because of the wide spectrum. It occurs nearly or more than half of the people who are having dementia. They experience this kind of Bpsd. So up to 3/4 or 84% of this is clinically significant or clinically significant
Dr. Norazam, are you still there? Probably, yeah. Dr. Norazam, sorry.
Level and the severity of cognitive impairment, all this influence the prevalence of Bpsd in the community. People who have MCI stands for mild cognitive impairment, they are having higher rate of Bpsd because Bpsd than the healthy people. People, they have not been diagnosed as dementia yet, but they are in the group of MCI, mild cognitive impairment. Those who are having mild cognitive impairment, especially the amnesia type, which 50% might convert to Alzheimer's disease, they might have Ptsd, such as depression and apathy, because they're having insight of their problem. They know there's something wrong with their memory, which they couldn't figure out why they are having this problem. Initially, they can remember quite well, they can function quite well. However, because of the under the category of MCI, nearly half of them might have depression. Okay, and 30% of them might having apathy. Apathy means that their lack of motivation, no goal-directed planning or cognition, decrease in emotional engagement with people. They are not really showing their emotion. So this is what we call as apathy. So people who are having MCI, they have increased incidence of depression and apathy before they are entering a full-blown dementia. Next, please. Next slide. Okay, if we look at the timeline there, zero is the time of diagnosis of being made by the doctor. Okay, so less negative is the time before they come to see a doctor and been diagnosed as having dementia. So the problem they might encounter probably 40 months prior to the diagnosis. If you can see the person who are having cognitive impairment, they might show that they're having withdrawal, they are not mixing with other people. They try to isolate themselves. They start to be depressed because of this one. They can meet up with their friends, but because of the cognition, they could not communicate, or they cannot convey the message well to the colleague. So this might end up with depression among them. So depression, and sometimes the early part of cognitive impairment, early stage, they might have sometimes suicidal ideas while they're having why couldn't they function as like before? So it might occur around 20 months prior to the diagnosis. Okay, so anxiety, paranoia sometimes start before the diagnosis has been made. So when the diagnosis has been made, they start to be quite irritable because they couldn't find where they put their things. They have to then tendency to wander around because they sometimes lost in the usual places that they are quite familiar with before. They have started to have mood changes. And towards the end of the spectrum, probably 20 months after the diagnosis, they start to have hallucinatory behavior, delusional thought, and even they might manifest aggression in their behavior. So probably it can occur though many months before the diagnosis has been made. Okay, next slide, please. So according to the Dr. D. Lind, so many of the patient might have the symptom that I mentioned just now. Either depression, very common. affective disorder, especially depression. It is between moderate to high incidence that is reportedly quite in many of the literature. Okay, hallucination and the psychosis is not too common as compared to the affective, but it is there. Like example, like hallucination. From the 11 studies, the occurrence of hallucination, it's about low to moderate as compared to depression and anxiety, which is quite high among them. And hyperactivity among the patients who are having dementia also is quite high. They manifest with agitation, irritability. So this is quite common among them, and it's reported in the articles. Okay, all right. Next slide, please. Next slide, okay. So the most common Bpsd, as I've mentioned, it is on the apathy, aggression, wandering. Sometimes it is purposeless wandering, where we don't know where they are going, walking around in the house as if they are trying to find something. So this is quite common. Restlessness and eating problem. Their eating pattern has been quite erratic. This is the most common behavioral symptom that they might manifest. The other, like agitation, disinhibition, okay, screaming, sound downing, especially during at night. They're having, during the daytime they are quite okay, but at night or evening time they started to be quite restless. This is also a common occurrence among the people with dementia. The less common one, like crying, it depends on the location of the problem in the brain. I think it is cortical or subcortical. The accumulation of tau protein or the accumulation of the amyloid plaque, which is if it is common, if it is in the subcortical, probably they might have cerebral effect or crying without any reason. Okay, this is which is less common. Most of the, if it is Alzheimer's, most of the accumulation of tau protein or accumulation of the amyloid plaque usually in the cortical region, which affect their emotion, which affect their executive function. Okay. Among the psychological symptoms, the most common one, as I mentioned just now, depression, anxiety, sleep problem, and family members with a different name. They couldn't identify their wife sometimes, and they call their wife as their mother. So this is example of misidentification. Okay, so basically, according to Colin Master, 2015, the phases initially they start with depression, irritability, nighttime behavior, as I mentioned, so it's a sound downing, and then followed by anxiety, appetite changes, apathy, and okay, the third phase probably hallucination, delusion, and disinhibition. So they have clusters as a symptom cluster also, and according to the phase. Next slide, please. And there are a few types of dementia, where the most common one is AD, Alzheimer's disease. Alzheimer's disease, they presented with more common with apathy, agitation, depression, anxiety, and towards the end, or if it is severe or advanced stage, hallucination and delusion might set in. For vascular type of dementia, very marked in their apathy, depression, as I mentioned just now. Also, the emotional incontinence, which is quite common. People who are in vascular dementia, emotional instability or emotional incontinence. Okay, euphoria with trivial euphoria, increase in mood with trivial matters, or they cry when we ask them how are you, and they start crying. Probably this vascular, they might present with this. ABM is aberrant motor or behavior. Aberrant motor behavior means inability to sit still, wanting to wander around, pacing, fidgeting, and this is very common in vascular. Okay, and mixed type is combination of presentation in Alzheimer's and vascular. And Lewy body dementia, it is quite rare, around 5%. 5 to 10%, but it is their presentation is a little bit unique in the sense that they presented to us with hallucination first, especially visual hallucination, which is quite distressing to the family, to the patient and the family members, because they can describe clearly what they see. If there's description there, it is a vivid visual hallucination. They can describe the color, how many people, they can give a proper description. This is Lewy body, on top of the cognitive problem and on top of the motor symptoms that they might present. They might present it with similar to Parkinson disease presentation. Okay. And they also have sleep disturbance, more on the REM sleep, which is presented with nightmare, night terrors in Lewy body. And frontotemporal, which is also a rare occurrence, it can happen in 5% of the dementia. They presented with very much apathy and disinhibition. Disinhibition that they couldn't control their behavior, touching people here and there inappropriately, and sometimes not wearing their clothes, going out walking around in the hall without any clothes. So this frontotemporal is quite dementia. Frontotemporal dementia is quite distressing to the other family members, because the patient couldn't control themselves in terms of obsession, compulsive behavior, doing things many times, and hypersexuality, as I mentioned just now. They couldn't control their if they interested in a lady, they just go to the lady and just hug the lady, even though the lady is not their family members or it's not their wife. So this is quite distressing to the family members. All right, next slide, please. Next slide, please. Okay. If it is across culture, in the research by Dr. Ferry and David Ames in a dementia research group among 17 countries, they divide India on the white column, LAC, the Caribbean, Latin America, Caribbean countries, and China. You can see that the Indian continent, they presented with more of physical problem like agitation, wandering, and sleep disturbance. For Latin America, they are more like a vocal, such as saying cursing and saying bad things, bad words to the other people. Like you can see in China, more on the agitation and sleep disturbance. So basically, different culture with different presentation depends on the depends on the expression of the in their culture. Okay, but anyway, anyhow, depression is quite common among across the culture. Depression and anxiety, it is across the culture. They are very common across culture. All right, next slide, please. Okay, according to this is in Asia, Thailand. Okay, if we can, according to Dr. Su and Kim, 90% having at least one Bpsd. So if it is 4, nearly half having 4 or more of the Bpsd. Okay, and the presentation similar, as I mentioned just now, is the irritability and apathy, and in Thailand. And in Japan, or more on apathy, they are not talking much. They are not really bothered about what's happening surrounding them. This is what happened in Japan. Next slide, please. Okay. As I mentioned just now, there's a difference between cortical and subcortical, presentation. Okay. If it is occurring in the cortical area, they are having much more score because the score towards the mood is occupying many of the presentation, that's such as depression, anxiety, okay, and wandering. This is more on cortical presentation, okay, and for cortical vascular dementia, okay, as compared to the subcortical vascular dementia, okay. And according to Dr. Professor Chanararong in Thailand, the AIDL it correlate with agitation, apathy. They couldn't do the instrumental ADL anymore. They couldn't do how to function at home. They couldn't change the bulb of the lighting. They cannot do their activity in the kitchen. They might cause agitation and other problem in the household. Next slide, please. All right. This is done by Dr. Suraya and team while she was in HSI, and among the patients who presented to psychiatric department memory clinic in HSI, many of them presented with irritability. 61%. If you see at the column at the middle, irritability stands out as compared to the others. Agitation and depression also on the high side. Okay, as compared to the delusion is only 30% of the presentation of the reason that the family members brought the patient to the memory clinic in HSI. Next one, please. Okay, according to Dr. Kamisa, agitation, apathy, irritability also among the patient who are severely dementia or moderately dementia. Okay, agitation and apathy and also irritability is on top of the list of the cause of Bpsd in Malaysia. Okay, next slide, please. Okay, psychosis, which is quite distressing to the patient and to the family members. It occurs, if you can see, overall, the most common one which is presented with psychosis is DLB, which I mentioned, dementia of Lewy body. 75% they present as we have discussed just now. They presented with a vivid visual hallucination. Okay, the hallucination can goes up to more than 70% of the people presented with in the clinic. So we have to suspect that the patient is having dementia of Lewy body on top of our list. Okay. As compared to the to AD, Alzheimer's disease, the psychosis only occur about 30%. Parkinson's vascular only 15%. It's not too high, but we have to put it on top of our list that TLB, if the patient presented with psychosis at the initial phase of dementia, DLB is the first. It's the top differential diagnosis that we have to think about. Parkinson's disease dementia. It is a Parkinson's disease which has been established, which has been diagnosed by a physician or by a neurologist for quite some time, or probably many years, and then they develop dementia. So the prevalence of psychosis among the Parkinson disease dementia is also very common, especially sometimes, especially when the patient is taking anti-Parkinson medication, because anti-Parkinson medication is the role of the anti-Parkinson medication is to increase the dopamine neurotransmitter. So dopamine neurotransmitter, increase the dopamine neurotransmitter at the same time might increase the occurrence of psychosis in the patient. Okay. Frontotemporal is very uncommon to have psychosis. Okay, next slide, please. So there's psychosis. Dementia, as I mentioned, is very common. Around 40% of people who are having dementia, and it can occur with many years, many months before the diagnosis has been made, and it is 4 times than the normal population. Okay, so very common, especially when the patient is experiencing or diagnosed by doctor to have vascular dementia. Okay, so they are either it is a primary because of the vascular event that happening in the brain, or it is secondary because of the motor symptom that they develop after having vascular events such as CVA, stroke, TIA. The consequence of the physical symptom, the consequence of the motor problem that they have might cause the patient to experience depression. Okay, and it is very common among people who are living in the institution, such as in the nursing home. Very common to have. When you go to the nursing home, after our lockdown, probably you can have a visit to a nursing home, and then we can ask the elderly people, "Are you happy to be in the nursing home?" Most of the answer will be, they're not happy there. Yeah, they're not happy. They want to go back home, but because of no one can take care of them at home, so they need to be in the nursing home. But their mood or their depression is very common among them. Okay, so it is when the depression sets in on top of the dementia, it can cause more functional impairment because they have lack of motivation to look after themselves. At the same time, to take care of themselves and to do their usual routine. They are not really interested to do that anymore. On top of their cognitive problem that they have. So this is, and depression, as you know, people who are having depression, they are high likely to have severe problem and higher morbidity among the people who are having depression on top of their dementia after of the cognitive problem. So this is a depression within 6 months of death is very common. So we have to find out. Apart from we are screening for cognitive issue by using our standard minimal testing examination tools or MOCA, Montreal cognitive assessment. We have to assess depression. We have to screen for depression as well. So the commonly used is geriatric depression scale, or when the patient is having dementia. So what you want to do? So we have to use another scale that what we call as Cornell scale to find out if the patient is having depression on top of their dementia. Okay, next slide, please. So we have touched about psychosis. We have touched about depression. Okay, what we know, depression, it is slightly different. The presentation is slightly different for MDD, because basically because the elderly, they could not express themselves. So there's a different according to DSM, Diagnostic Statistical Manual of Mental Disorder. So we have to differentiate between these two. Not differentiate. I mean, we have to we have to aware that the presentation might be different from MDD, such as okay, if the patient is having patient is having depressed mood, or the patient is having social isolation changes in their presentation, they are much more isolating themselves, change in appetite, change in sleep, becoming more irritable. Probably we have to find out whether the patient is having depression or not. So as compared to the general population having depression. Okay, so we have to use a different diagnostic criteria. Okay, next, Farah, please. Next slide, please. Okay. So after depression is apathy. Apathy basically is lack of motivation, diminished goal-directed behavior, decreased emotional engagement. This is very common. And the apathy in dementia, especially AD, it can goes up to almost 90% of the people who are having dementia, either AD, DLB, or FTD. Okay, so this is very, very common, this is causing distress to the family members because they are not themselves anymore, or especially the loved one, the wife, they could not engage with the husband who having memory problem because of apathy. So the distress is towards the family members is higher than the people who are having dementia presented with apathy. Okay, next one. Next step. And so, and anxiety also is quite common because they are lost in the family environment. So, which causing them to experience anxiety. Okay. So it can happen in 70% of the people who are having dementia, especially when they are having insight of their illness. The early phase of dementia, when they are still having insight, the insight is still retained. They are a little bit anxious because they could not function as usual. They cannot solve the problem as usual. They cannot think as usual. So this can cause anxiety among them and causing negative impact and cause worsening diagnosis. All right, prognosis. Okay, thanks. Next one, please. So the patient is having depression. We have depression. We have psychosis. The patient is having apathy. The patient is having anxiety, anxious. So for agitation is very, very common. There's the commonest reason that the patient was brought into to see in clinic. So agitation is very causing distress to the family members because of the anxiety that they have, because of the depression that they have. They might manifest in terms of aggressive behavior or in terms of agitation, and this can cause distress to the family members. Agitation or the aggression can be either physical or can be verbal. So this is the presentation can be verbal or vocal. All right, and it is very common in the people who have dementia. Next slide, please. Next, please. Okay. Wandering behavior. Yes. As I mentioned just now, the wandering behavior, patient has been walking around, they're feeling lost. Sometimes they go to the kitchen, they try to find something. Initially, they thought they can remember. When they go to the kitchen, they couldn't find. Does it sound similar? Sound familiar or not? I think some of us also can experience this also. Initially, we want to find something in our room, and then when they go to our room, we cannot remember what are we looking or what are we searching. So this is much worse if the patient is having dementia. They are lost in their family environment, in their own house, in their own room. They don't know where they are whereabouts. Okay, so wanderers can be quite troublesome to the patient because they increase anxiety to the patient, and then they end up with agitation or wandering, especially wandering at night. This can cause distress to the family members because family members at the same time the family members wants to it's a resting time at night, but 2 o'clock, the patient has already woke up and tried to walk around in the house, not knowing where to go. All right. So wandering is another Bpsd which is quite common and cause distress to the patient and family members. All right. Next one, please. Okay. Sleep disturbance. It can occur in many of our patients. 80% of patients who are having dementia. If it is DLB, dementia of Lewy body, the REM sleep, it is very common to have experience this REM sleep disorder, such as I mentioned just now, is like night terrors, bad dreams, okay, which is very common in the DLB, and Parkinson disease disorder, Parkinson disease dementia. Sometimes because of the anti-Parkinson medication that they are taking, causing REM sleep behavior. So irregular sleep-wake cycle, it is very common in AD, reversal sleep cycle, reversal of sleep cycle, sleep-wake cycle. They sleep more in the daytime and wake up during the night time. So yeah, so this is very common in AD. All right. Okay, next one, please. So as I've mentioned, this is the summary of that of what I've mentioned, the etiology or factors in Bpsd. Okay, next, please. Okay, this slide showed that the Bpsd, when it occurs, you have to find the factors which causing it. Either it is a patient factor, or caregiver factor, or it is an environment factor. We try to find out the factor which contribute to the Bpsd. Okay, either it is, example is environmental factor. It is either is too hot or too cold, or overstimulation, too noisy, or understimulation, not having no stimulus at all. All this can contribute to the Bpsd among people who are having dementia. Or it is either because of the caregiver factor, the way that the caregiver respond to the people with dementia who have Bpsd, the way sometimes it can cause irritability to the patient of having dementia. Okay, because the way that the caregivers respond to them. Okay, so communication issue is the problem between the people, family members, and the expectation of the family members and the people who have dementia, or the expectation of the family members. Family members thought that the patient can look after themselves, but the patient who have dementia having difficulty to find the way to the toilet, example, end up with having incontinence. Not really incontinence, but they couldn't stand anymore. They couldn't hold their bladder, and then they end up with passing urine on the way to find the location of their toilet. So the expectation of the family members and the dementia people also can contribute to the Bpsd. Or is it the patient factor itself? Very much depends on the premorbid, what type of person that he or she was before having dementia. If the patient who is always working outside of the house, especially during this lockdown, and they having dementia or they having cognitive impairment, although the Prime Minister said stay at home, stay safe, don't go out, but because of their having cognitive impairment, they want to go out because that is their nature. They want to go out. So this is the problem sometimes among people who are dementia. At the same time, they are in this pandemic, during this pandemic. So very much depends on the premorbid routines, premorbid personality the patient is patient has before this. Okay, so and we have to find out the patient factor, either the patient is having pain or not. Sometimes they couldn't express that they're having pain, toothache, back pain. headache. They couldn't experience, they couldn't express it out. So end up with more on physical manifestation, walking around, try to find things, try to find, actually he wants to find his tablets, but couldn't find, and couldn't say it to the family members, but he presented with wandering around. So if the patient is having this kind of problem, we have to find any pain issue or not. The parents have pain issue or not. All right. So patient, remember, patient factor, family factors or caregiver factor, or environmental factor. Next slide, please. See, this is the model in the cartoon. So for the public, this is basically for the public. Okay, next. Next slide, please. Okay. So as I mentioned just now, it is idea is unmet needs. So example, because of the pain issue, and he wants to find his tablet, but he couldn't find his tablet. He presented with wandering. Okay. Or it is a learning model factor, because he wants. He learns from the previous response by the family members. He said that if he wants to go out and the family reward him with some activity or some token, and he can stay still. But if the family members couldn't give the same reward, same token, he might present it with Bpsd, problem with behavior. Okay, or is it because of the stress threshold? Stress threshold meaning that having changes in the environment can easily cause him to develop Bpsd or agitation or irritability, because he couldn't control anymore. There's no buffer between his thinking and his behavior, like normal people like us, because there's no buffer. If they want something, they show it in their behavior. So this is a threshold model. Okay, next one, please. Okay, as I mentioned, this is more on the assessment and in the unmet model. Okay, next one, please. Okay, so yeah, as I mentioned just now, we have to find the A, B, and C. Behavior. What is the behavior? We start with B first. Behavior issue. Is the patient manifesting with some character in their behavior? So what behavior? Describe the behavior. And then we go back. What's A? Why does he present it with this behavior? Is he having patient's factor, caregiver factor, or the environmental factor? We try to find what A is. Okay. And see what's the consequence of the behavior. If the behavior causing consequence safety issue to the patient, or is it a safety issue to the family members, or causing distress to the family members? So what are the consequences of the behavior? So we start with B, and then we go back and try to find A, patient factor, environmental factor, or family factors, and we go forward to see what is the consequence of it. So A, remember, A, B, and C. Next, please. Next, please. Okay. This is as I mentioned, because of the there's no less buffer between the thinking process and the behavior, causing them to have a very low stress threshold. Can easily, let's say, when they feel pain, they can easily get agitation. They can easily get irritability. Okay, next, please. Okay, so caregiver, when they're experiencing this, they have to be aware, okay, of this Bpsd among the people who are having dementia. Okay, try to monitor and communicate with the patient. If they couldn't, try to get assistance from the health providers. We in Permai, we have our clinic every Tuesday. Every Tuesday we have the session. A few of we have a team which can give education to the family members and some interaction, Q&A, so on how to do. And we are starting a program what we call as CST, cognitive stimulation therapy, basically to stimulate the people who are having dementia on using more on cognitive process, so that they can occupy their time. Okay, so for household tasks, the family members have to a little bit have the responsibility to help the patient, and in terms of personal care, and of course the end of life care also. And we have to educate the families to about their expectations. Sometimes the expectations too high. Example, boleh tak doktor bagi ubat kasih baik ni mak saya macam dulu? Is there any magic tablets or not? The answer is no. We are very sorry about that. If it is a primary dementia, as I mentioned, primary dementia, AD, dementia of the body, frontotemporal. It is more on primary dementia. There's no turning back. If it is a reversible kind of dementia, example, thyroid problem or depression, probably we can there's a little bit of the medication might help, but for primary dementia, there's no medication to turn the clock back. All right. Bereavement issue also we have to prepare the family members that his or your mom or your dad is not going to be like before, so get prepared. Okay, and expectation also have to be reasonable. Okay, next issue. Next slide, please. Okay, this is the impact. They are very much, the family members is very much affected. 66%, more than half of this. And sometimes they have to give up their work to look after their elderly parents in the kampong or at home. They have to give up because there's no one to look after the family members in the kampong or in the house. If they need to send to the nursing home, so they have to prepare a little bit of money to prepare, and the cost is not cheap. So caregivers, we have to look after the caregivers as well, especially when the caregivers is having depression, burnout issues. They are having exhaustion. Sometimes in Permai, sometimes we offer a respite care also, but not all. I have one patient initially was frequently being admitted, but after explaining to the family members that we offer respite, if you have problem looking after her, looking after your mom, you can send to Permai with a certain period, let's say 1 week or 2 weeks. Probably the family want to take a break. Okay, there's one patient that they are willing to do that, and we offer them also. Okay, this is a kind of respite for the family and very much needed. Okay, next slide, please. This is the summary of my talk. Bpsd can cause burden, can cause increased expenses, time to look after, and social isolation. The families couldn't go out, couldn't work, basically because they have to look after their elderly parents who are having cognitive problem. This can cause stress and can cause illness to the family members or to the patient, and causing a poor quality of life and distress. All right, next. This is the little bit of study on the caregivers burden, and it is very much affected to the Chinese population in a study by Dr. Chu in 2003. basically all has been affected, but it seems that Chinese is much more having a burden to look after people who are having dementia. All right. So with this, we have to support the family who are having have to look after their parents who are having dementia by assistance such as maid, private nurses. We don't have meals on wheels, but if we can provide that, is good for people who are having dementia. We want to encourage them to stay at home as long as possible, aging in place if they prefer to be alone. But the support system have to be there, to help them to stay in the community as long as possible. Okay. Next. Okay. As I mentioned just now, this causing caregiver distress. Okay. Especially when the patient is having aggression, agitation, delusion, or aberrant motor behavior. All this contribute to the caregiver distress. Next issue. Okay, this is a study, as I mentioned just now, is a study on the by Dr. David Ames and Dr. Ferry on the 1066 study across developing countries. I mentioned about the India, Latin America, and China. This is the result of that. Next, please. Okay, conclusion. In conclusion, Bpsd, it is not a small matter. It is a very important and essential part of treating, managing people who have dementia. Not only people who have dementia, but also the caregivers. It is an essential part of the management. We have to deal with it from the beginning. Okay, and we try to find a comprehensive approach on how to help the patient and also the caregivers to take care of the people as long as possible in the community or in their familiar place. Okay. All right, with that I conclude. Thank you very much for your attention, and I have to excuse myself. I need to go to Hospital Permai because Hospital Permai, you know that from Hospital Permai, they are going to set up a PKRC. So I need to see how are the setting. Okay. Thank you very much. Thank you very much for your attention, and patuh SOP. Stay at home. If no urgent matter, don't go out. Wear your mask everywhere. If possible, double mask, and use face shield. Okay. Thank you very much.
Thank you so much, Dr. Norazam, for the very informative session that covers the dementia definition, prevalence, types, and etiology, as well as the impact to the caregivers. So since Dr. Norazam will have to leave now, so all questions will be answered by Dr. Suraya at the end of the session later. So once again, thank you very much, Dr. Norazam. All right, so now we will proceed to the second part by Dr. Suraya that will focus on the assessment and management of dementia. Over to you, Dr. Suraya.
Okay. All right. Okay. Hello. Good morning. I'm Dr. Suraya. Okay. This is a pretty heavy Saturday morning. So for the remaining participants who are still around, thank you very much for staying around. Okay. We still have a lot to cover. Okay. So this is the learning objective this morning. So I hope if you don't learn anything else, at least I learned about some practical and simple instrument to use in assessing behavior in clinical practice. Okay, I'll try to go through all these learning objectives as fast as I can because I don't want it to be too long. Right, so these are the contents of my talk for today. How we approach patients with Bpsd, how to assess, some risk assessment to help guide you, the non-pharmacological interventions and pharmacological interventions, and what are the evidence base that we have for these interventions. Okay, just a quick recap that when Aloy Alzheimer in 1906 reported about his patients, the prominent symptoms that he sort of described is actually the behavior psychological symptoms of dementia. Okay, not so much the cognitive portion of it, right? So after going through all the etiological factors that were put up by Dr. Azam, what is clear is that the understanding of the prevalence and risk factors for Bpsd is the first step in developing your management plan, okay, as well as drawing up policies for the management as yet. But what is yet unclear is whether this Bpsd is the epiphenomena of a neurodegenerative process of the dementing illness itself, or whether it's symptoms of specific biologically distinct subtypes of dementing disorders. So that's not very clear. Okay, so when we when we manage patients with dementia, our goals of treatments are all this, you know, you wanted to maintain the quality of life, you want to maintain the activities of daily living in the patients as long as possible. You want to foster a safe environment for the patient, and you would want to promote social engagement. But another aspect of the goal of therapy is also to enhance your cognition, your mood, and your behavior as well. Okay, let's look at the assessment of the behavior and psychological symptoms of dementia. Okay, the approach to behavior problems is simple. Okay, is this behavior new or is it an old existing problem, right? Because your management will depend on these two factors. Right, this is basically the algorithm, not only for assessing behavioral psychological symptoms of dementia, but for assessing a dementia in general. You know, you would want to obtain a good history. You want to proceed with a physical and neurological examination, which is mandatory. You would want to order the lab and diagnostic imaging tests, okay? You would want to treat whatever medical or neurological disorders that is associated with the dementia and with the Bpsd itself. If you have identified drugs that cause the Bpsd, of course, you want to remove the drugs, okay? There are certain instruments that you can use to rate the Bpsd as well. So in centers that deal with memory problems, it is encouraged actually to use the standard rating scales as a baseline, you know, because you would want to see whether following your treatment, your management of the Bpsd, there is a worsening or improvement in the symptoms itself. Then of course, you would also want to assess the severity of dementia. And again, there are a lot of cognitive rating scales which you can use for this. Okay, right. But in the assessment of Bpsd, don't forget to look at these factors, you know, your physical factors, your intellectual factors, cognition, the 7 A's, example, agnosia, apraxia, and so on. Your emotions, capacity, your environment, and the social cultural. I'm not going to touch on capacity in this talk, right? Okay, the first thing to do is to screen actually and treat delirium, because that's one of the major causes of Bpsd, your physical illness, right? So you need to rule out physical illness, particularly if this Bpsd is a new emerging problem in the patient, right? But you want also to look through this toxicity, things, substance that can cause toxicity in the patient, which will worsen Bpsd, and of course pain, right? We'll go through pain a bit more after this, and also sensory impairment, don't forget, it can also worsen your Bpsd, okay? Your hearing, your vision, all that. Okay, so the most important issue is to rule out delirium. Okay, because delirium secondary to an underlying condition is the most common cause of recent and sudden behavioral disturbance in people with dementia. And please remember that delirium is often misdiagnosed as depression or dementia. Whether you are a medical student, you are a postgraduate student, never forget delirium as a differential diagnosis of not only dementia, but Bpsd in dementia as well. Okay, just to give you a brief outline of what CAM is all about. I am sure a lot of people knows CAM. Definitely the students from Newcastle University has been taught how to use confusion assessment method, right? It's also very important for those who works in the medical wards, who works in the ED as well, because they might be the first line of health workers who sees the patient, right? So for CAM, as you know, there are 4 points in CAM. The first two, which is acute onset and fluctuating cause, must be present together with the lack of attention. After all, delirium is a disorder of inattention, right? And you must have either 3 and 4 symptoms, which is disorganized thinking and altered level of consciousness. So you need at least a score of 3 for you to diagnose delirium in the patients. Okay, and then rule out pain. Okay, because pain is present in more than 50% of people with dementia. Behavioral disorders in general and verbal agitation in particular have been shown to be associated with pain. Okay, in an 8-week multi-center RCT study, it found that the effect of a stepwise empiric treatment of pain in people with dementia, which is related with agitation, that the treatment of pain itself can reduce agitation in about 17% of patients, okay, who has this empiric treatment of pain. And this results actually is comparable to the use of risperidone in among these patients, right? But then you don't have those adverse events on cognition and physical functioning, which you can get from the use of risperidone. Okay, so pain, as we know, is a non-specific indicator of distress, not only for people with dementia, but in children as well. Okay, but the problem with people with dementia is that they are not able to verbalize pain, right? So they can't tell you that they are in pain. And you know that if they cannot control pain well, then this will result in sleep disturbances, depression, agitation, and leads to a slower recovery after surgery as well. Well, we can use the normal scale that you use in the ward to assess pain in people with dementia, because they might not be able to understand it. Okay, even if you show the different types of faces, also they may not be able to have that cognitive presence enough to be able to say how they feel. Okay, so you might use some other pain scale. Okay, I think the Ministry of Health uses the FLAG scale for pediatric in the pediatric group to detect pain. That can be applied for people with dementia as well, because you don't need patients to verbalize the pain. It's up to the observer to detect all these changes in the patient to sort of rate the pain that he or she is facing at the moment, right? So the most suitable pain scale in people with dementia is if you can look at the way they breathe, the noisier the breathing, the possibility of the higher the pain that they have is there. And you also need to look at the facial expression, whether they look content, they look sad, they look frightened, or they frown all the time. Okay, also we need to look at the negative vocalization, the body language of the patient, and how much they can be consoled. Okay, for AD, there is a pain-specific AD scale that you can use, right? But either one is okay, whatever you have with you. Okay, so next one. Okay, right. So we sort of, if you find that, you know, patient is not delirious and neither the patient has pain, then you will go on to assess other behavior and psychological symptoms of dementia. I think the first three, Dr. Azam and I have recovered some of it. So we are only going to concentrate on the risks associated with behavior and the other areas of concern. Right, with regards to measures of behavior, this can serve as baseline, right? So it doesn't matter which sort of rating instruments you use, or some have been validated for people with dementia in the country, some have not, right? NPI is used, is the favorite one among all the list that I have here, but definitely you can use your brief psychiatric rating scales, right? The same rating scales that you use to rate symptoms for schizophrenia patients. Actually, you can use that as well, because it has been shown that it makes some difference. It is as good as NPI actually, right? But NPI is very simple to do. Right, so the depression scale, as Dr. Azam has mentioned, you can use the GDS, Cornell scale for dementia. There are many different types of GDS. You can use a GDS-4, just 4 questions. You can use GDS-5, or what we normally use in our clinic is GDS-15, right? But it doesn't matter which you choose. Okay, for agitation, you can use the Cohen-Mansfield agitation inventory, again, which simple, and I think it has been translated. I cannot say that it has been validated for use in Malaysia, but it is definitely have been translated in Bahasa Malaysia. And for caregiver distress, GHQ can be used, General Health Questionnaire, that has been validated for the Malaysian populations, or NPI itself have a caregiver scale at the end of it. So you can use that to form a baseline of measure as well. Okay, but one thing you have to remember about using these skills is that the currently available tools do lack, because of the lack of diagnostic criteria for specific behavior, it might be a disadvantage to the use of quantitative tools, especially in research, right? Currently, we only have the diagnostic criteria limited to psychosis and depression only, which Dr. Azam has gone through in his lecture. But the criteria for apathy is in the work and has been proposed. It should be completed by now, because that was a few years ago. Right, so we move on to the assessment of risk, the degree of risk in the patient, right? Not only patients living at home, but patients in long-term care as well. The assessment of safety in people with dementia, but especially those with Ptsd, must be considered because in the context of developing a management plan, because you need to identify risks and then give intervention accordingly, right? So there are questions that you need to answer when you do a risk assessment, right? Who is at risk? Is it the patient? Is it the caregiver? You need to also consider the area of risk, okay, the degree or likelihood of risk. How imminent is it? Is it increasing? Is it decreasing? Is it newly emergent? Is it urgent? Is it non-urgent? And so on. Also consider the potential consequences of the risk and the capacity of the patients, the caregiver, and the system to modify the risk. So that have to be questioned. Okay, there are two ways to assess risk. For those people who love mnemonics, very easy. You can use the simplified risk assessment. Okay, the mnemonic is risk itself. R for roaming, I for imminent danger, S for suicide, K for kinship, and S for safety. Or if you want to go into more detail, then you would want to split up into risk according to who? Is it according to self? Is it harm to others? Does it cause harm from others and other risks? Okay, so I have outlined in the table what are the harm to self, what are the harm to others that you need to look into, what are the harms from others that you also need to look, right? And also other risk factors, right? Whether it results in accommodation loss, it results in carer stress, it results in social isolation, or it results in a poisonous environment. Okay, another context to consider is the environment itself. Okay, a supportive environment will definitely help the patient to maintain his or her abilities. If not, it can lead to behavioral changes. So home safety is an important component of assessment. So it's good if you have a team who manages this patient, and your occupational therapists can sort of go and assess the home environment itself and suggest the appropriate changes that needs to be done that can reduce Bpsd, the risk of Bpsd. Okay. Oops, next. Okay. And when you plan the management for this patient, there are some contexts that needs to be considered as well. Most people actually forget about the social and the cultural factors, but you need to know your patient. We are in a multiracial country, and that can be an issue as well, because certain beliefs in the patient may lead to the healthcare provider think that he has a paranoid delusion, whereas it's probably part of his social and cultural issue, right? So each person has unique social and cultural needs and support, and this can only be met through individualized approach. Okay, so some immediate social network can also give a profound effect on the patient's well-being and will guide the action, the steps that you need to act. Okay, so there are 4 aspects of social and cultural that you need to go into detail: the patient's life history and the previous social networks that he or she has, the interaction and relationship with family and caregivers, the interaction with peers, and the normal social graces or lack of it, right? Because some people probably doesn't have that, you know, some graces were not taught on how to be graceful, which another culture might take for granted. You also need to look at patients' life accomplishments and their previous interests as well, as this will help you towards the psychological management of Pbsd. Okay, so we go into the treatment of Pbsd itself, right? So it's not so easy. In fact, treatment is very complex and may require several interventions as part of a comprehensive care plan. So it's not as if you go for one visit then you can sort it out. Okay, it may require multiple reviews, multiple visits as well. But the aim of the treatment of Bpsd is to reduce the frequency and intensity rather than to completely eliminate these behavior changes. Okay, just remember that, just keep that in mind. Okay, there is an interaction, there definitely has to be an interaction between the provider, the patient, the provider, the caregiver, the patient, and the caregiver when you initiate behavior treatment for Ptsd. Okay, we will look into the psychological treatment as well as the pharmacological treatment as well. Okay, how the patient respond to the caregiver also can worsen the Ptsd. Just remember that. Okay, so in treating behavior symptoms, I'm going to split up into two, which is a non-pharmacological. Right, so what evidence that we have so far? Okay, definitely when we manage the patient, you need to have evidence. You cannot just go in and manage as you like, right? So NICE, whether in 2006 or the NICE in 2018, and as well as the Malaysian CPG also, recommends the use of treatment using non-pharmacological approach in the initial stage when you manage this behavior, right? So psychosocial, behavioral, environmental interventions are recommended as first-line treatment of Pbsd, right? So NICE also recommends personalized activities in people with dementia, particularly those with agitation or aggression. And you can do this by promoting engagement, pleasure, and interest in the patient. Okay, but if you need behavior strategies to manage Ptsd, just remember that, it has to be multi-component, and you need caregivers, whether it's paid caregivers or whether it's family caregivers, to be involved and to be trained, right? But definitely with multi-component intervention for caregivers, there is wanted actually chances of institutionalization, particularly in those with mild to moderately severe AD. Okay, so other psychological therapies that do have evidence, low to moderate, your CBT, again, plus multifaceted and semi-tailored intervention. They have low to moderate evidence. Music-based therapy, as opposed to usual care, also shows moderate evidence to control behavior problems. Okay, it does reduce depressive symptoms, and it does show an overall reduction in behavior problem as well. Aromatherapy against placebo have been tried, but the evidence is very low. Okay, massage and touch versus daily routine care or being accompanied, that also shows low to moderate evidence for improvement. Okay, validation therapy against the usual therapy also doesn't have that much evidence, so it's quite low. Light therapy does show moderate evidence, but light therapy is probably more useful in people who faces winter season. Malaysia is most of the time having sunshine most of the time. Okay, simulated presence therapy also shows very low grade evidence, so it's inconclusive recommendation. Snooze length versus control, very low. So don't waste your money buying snooze length for your hospital. Okay, but remember, although the evidence says such, but you have to remember that it's not very easy to get data for non-pharmacological interventions. It's very inconsistent. So far, the papers showed that patients are heterogeneous, right? It can be dementia, different types of dementia as well, right? So it's still up to today, it's not easy to make a firm conclusion about Bpsd, although it does help, but there's still insufficient evidence. But what you have to remember is that despite of insufficient evidence, there is a risk of mortality for non-pharma intervention, okay, rather than not doing anything about it. Okay. Right. So Bpsd itself you can actually classify it into two, emergent and non-emergent Bpsd, because the management of these two groups of people might differ, right? But the line between these two are not always clear. So what does it mean by emergent Bpsd? Okay, emergent Bpsd are those people who face Bpsd at the time of presentation. They are in severe distress, they pose an imminent danger to themselves or caregivers, and they have severely disruptive or dangerous behavior. So in their risk assessment is of course high. Whereas for non-emergent group of Bpsd, the symptoms may not be present or may not be severe at the time of evaluation, but the patient might have had severe symptoms before in the past, right? Okay, but at the moment when they come to see you, the baseline behavior is not too much of a bother to themselves or to other people, but the symptoms may be inconvenient and may disrupt their functioning in daily life, right? And could lead to an erosion in their quality of life. So in this group of patients, we probably have to use a different clinical and behavioral approach. Okay, right. So always remember this, let it be your mantra, that non-pharmacological intervention should always be considered as the first course of treatment, especially in non-emergent situation. Okay. Right, so before we can manage behavior, we just quickly go through all this. Dr. Azam has done all this. First, you have to be aware of the stages of the natural history of progression in dementia, because some of the behavior symptoms will emerge at different time, right? So in the mild stage of dementia, you can have your mood presentation, your depression, your social withdrawal, and so on. At this stage of mild dementia, your cognitive function will slowly start to decline, as well as your functional autonomy will also start to decline. Most of the behavior will emerge in the moderate or the severe dementia, and it can persist until you die, right? The behavior part of it, okay? So behavior is more related with the degree of functional impairment rather than correlation with cognitive impairment. So if you look at your line, it's nearer toward your functional autonomy, loss of functional autonomy. Okay, again, remember these slides that Dr. Azam has shown you earlier on: patient factors, caregiver factors, environmental factors, because you are going towards sorting those factors out in order to improve management, right? But you also have to give a benefit of the doubt when you manage the patient. You have to remember that some patients, some factors, no matter what you do, cannot be modified, okay? So forget about trying to make changes to these factors, right? But there are certain groups of factors which you can modify, and you use this as a guide to the type of psychological treatment that you want to choose. Okay, so again, the models of behavior, just a brief outline on what types of psychosocial intervention that you can do, right? For the unmet models, this is consistent with problem solving and the PCC approach. PCC is person-centered care approach to managing patients with dementia or patients with dementia with mild Bpsd, right? So your learning model is consistent with the ABC approach, as mentioned by Dr. Norazam. Or sometimes you want to use, you want to take this stress threshold model as the basis of the behavior. So in that case, this is more consistent with, it's not person-centered care approach. I'm sorry, that's a mistake there. It's dementia care mapping actually uses, is the basis for stress threshold model. Okay, So just again, to recap the goals of care, if you notice that I minus the emotion behavior problem because that's what we are dealing with now, right? So in order to maintain safety, modify communication, modify environment, and so on, it's important that the patient, you use this person-centered care approach. You have to remember that it's the person that you have to understand. You are dealing with the person themselves, not dealing just with the behavior or disease. Okay, the behavior, there is somebody behind the behavior and disease, right? So you have to understand your patient very well. Okay, if possible, we need a multidisciplinary and multi-team care because the expert from different health professions would assist you in coming up with a plan or imaging or managing the behavior in the patient. This is particularly so when handling Bpsd, and of course the legal and ethical responsibilities. The treatment that you are advocating, you are giving to the patient, whether it's within the scope of it being ethical, okay, or whether patient's family can bring up some legal issues in it, because you are dealing with a group of people that might have diminished capacity for consent. Okay, right. Just to highlight some general strategies in terms of environment, for people with dementia with Bpsd, you want the environment to be stable. So you try to minimize environmental change as much as possible. So if patient is in long-term care home, you have to limit the number of caregivers, right? If they keep changing room, that's not good for the patient as well. So you have to educate the staffs in the long-term care, right? So structure, if everything is in structure in place, the dementia patients doesn't like new things to be introduced. So you have to follow a strict structure actually, because that can bring improvement in the patient. And always remember that if patient is from home and they move to long-term care, you need to give them a time of adjustment before you add any antipsychotics or any medications to help control the behavior, because the patient might settle without any medication within the 4 weeks of living there. Okay. Okay, physical activities are also found to improve cognitive function in people with dementia. It also has been found to improve your Bpsd as well. Okay, I won't quote any studies here. I'm going to go quickly into it. The third behavior is, of course, stimulate. You want to stimulate the patient, but you don't want to stimulate too much because it can set off the patient as well. So make sure the room is not too noisy, and be aware if the patient is long-term care home, be aware of the shift changes, different group of staff coming in who are not familiar with the patient and so on. But too little stimulation also can cause problem as well. So do not isolate the patient. Try to reduce the loneliness for the patient, and so on. Okay, so another strategy is communication. Communication is important. You know what are the aspects of communication, and it does affect the way the people with dementia interpret your efforts at communication as well. It also affects the way that the people with dementia express themselves, and how much they can communicate is very much dependent on the stage and the types of dementia. So miscommunication can result in Bpsd as well. So if you want to do any strategies for patient in terms of communication, use a focused communication. Okay, again, these are mnemonics to help you remember easier. But always remember to pay attention to the non-verbal message. Okay, so learn to read the patient's movement. Okay, right. So problem solving is also a pragmatic and simple approach to Bpsd, and it's consistent with the Psd approach to care that organize potential explanations and care in the patient. It's part of the collaborative care approach to dementia as well. Okay, analyze, you need to have goal, you need to have strategy, give information, and so on. Okay, and staff training is also an ongoing staff training. By arming the patient, the staff with the appropriate knowledge, skills, and abilities, you can help improve the quality of care for the patients. Okay, because it's essential for the staff to stay informed on the current research. And it's found that education and training for the staff are effective in reducing the Bpsd, not only in the nursing home, but also in the community as well. So staff here is not only for staffs in long-term care home, but your staff as well. Staff helping you in the clinic, staff at the primary care center, and so on. Okay. So at the same time, do not forget the family intervention approach. Okay, so by providing caregiver with education and support, training in stress reduction, cognitive reframing techniques, or both, and giving them specific skills in problem solving can go a long way towards managing behavior. The New York University Caregiver Intervention Study, a long-term study on the cohort of family caregiver, found that those who have been given family intervention, 6% at least of the people with dementia still stays at home, and less people with dementia in the nursing home also reduce risk of dying as well, and they save a lot on Medicare as well. Okay, so the meta-analysis of RCTs also found that family care intervention can significantly reduce behavioral symptoms, effort size between 0.34, which is pretty good actually. And it does show better efficacy comparing to the trials of using antipsychotics, where your effort size is only 0.18. The use of cholinesterase inhibitor for cognition, also the effect size is very low, okay, at 0.15 for low dose and 0.28 at high dose. So again, you see that family intervention gives you a much higher effort size compared to all this treatment. Okay, so we move on towards medication in the treatment of Bpsd. I will cover some of these, all right, but not all. But I'm going to focus more on the use of antipsychotics and antidepressants, and according to the guidelines, whether it's the NICE guidelines or the Malaysian CPD guidelines. So first thing again, clinical guidelines recommend non-pharmacological approach as the first treatment of Bpsd, and any pharmacological therapy should only be initiated if the symptoms did not have any somatic causes or did not respond to non-pharmacological interventions and were not caused by prior medication, right? Okay, but despite of what is in the guidelines, you find that in reality, it is a totally different kettle of fish. Okay, this is three major studies of 3 psychogeriatric inpatients unit, and you see that in Australia, you see that the major medication groups at discharge of this patient are still benzodiazepine. Majority of the patients got benzodiazepine, and majority of patients also, 60 or more than 50%, got antipsychotics. Okay, so in reality, antipsychotic medication is often used as first-line treatment rather than as secondary alternative, no matter what the guideline says. Okay, behaviors such as agitation, aggression, psychosis, depression are more likely to respond to antipsychotics. Okay, we have to admit that, right? But most often, a majority of antipsychotic use are off-label use. Okay, so it's not actually recommended by majority of the countries. But of course, most countries doesn't have much regulatory rule of approval. Only Australia only says that you can use approved risperidone, and it is subsidized treatment as well. But in 70% of people with Bpsd, antipsychotics can actually be discontinued without worsening any symptoms. Okay, there are some behaviors which are very responsive to medication, right? And there are some behaviors that doesn't respond well at all. So do not waste your medication on this type of behavior, okay? So look into those that are responsive to medication only. Okay. So there are definitely some evidence for pharmacological interventions in Pbsd. In general, there is a modest benefit, but remember, you have significant potentials for side effects. Okay, the best evidence is for atypical antipsychotics. There's moderate evidence for antidepressants and very much weaker evidence for anticonvulsant, benzodiazepine, cognitive enhancers, ginkgo extract, particularly theobromine or your EGB 716. Okay, but remember, whichever medication you use, all choices are off-label usage unless you are in Australia. Okay, right. So again, the box shows the evidence, the systematic review of 24 meta-analyses on antipsychotics, ADP, AED, which support this, the use of antipsychotics, and ADP is your antidepressant. Okay, right. This is just to show you the trend of using antipsychotics, right? Because I think a few years ago, the Alzheimer's disease, ADI, Alzheimer's Disease International, actually advocate for the non-use of antipsychotic treatment in the control of Bpsd in dementia. And since that time, the National Dementia and Antipsychotic, the prescribing audit has been done on the use of antipsychotics in people with dementia. And they did found that there is a decrease in usage of antipsychotic prescription among these people after this promotion by the ADI. And the number of people with dementia receiving prescription of antipsychotics medication will also halve in a period of over 2 years, right? Okay, but this is a bit some time ago. Okay, the extent of use of antipsychotics in Bpsd in people with dementia in Asia, very poor data. It varies from 20.3 to 48% actually. Right, different countries have different prevalence on the use of antipsychotics, but the 53%, which seems to be high in India, is because it's a fixed population, it's a captured population of people with dementia in a geriatric clinic, and all these are mainly long-term care or studies in the health center, not actually in the community itself. So you found that a lot of people are on antipsychotics here. Even in JV also, we did an audit actually by Amira, one of the new medical student when she was doing the SSC posting. And we found that 31% of people attending our clinic are on antipsychotics, people with dementia attending our clinics. But is it worth it or not? Because according to the Getty study, although there is some effects of the antipsychotics on Pbsd, it's not actually significant as when compared to placebo, right? Okay, but on your right side, the reason why we should not use it, okay? Because it triples the rate of stroke, it doubles your mortality, it causes you to fall and lead to fracture, hence reduce quality of life. It has a lot of adverse events which are cumulative. It makes people gain weight and it causes metabolic syndrome. And at the end of it, it doubles your cognitive decline. So is it really worth it actually, right? It can have positive effects, but the harm that it causes to people with dementia is pretty high, okay? And it does found in the DART study that if you stop long-term antipsychotic, it does reduce mortality by at least 25% after 2 years of follow-up. So if you compare the use of antipsychotics in Bpsd as the cause of death as compared to other people with other problems, you find that those people in dementia with Bpsd definitely has a very much higher, double the hazard ratio compared to other people who is not dementia. Okay, but if you need to use antipsychotics, just follow these guidelines. For those who love mnemonics, again, we have mnemonics here. Okay, here is, you know, after you have done your physical examination, you have ruled out any health causes for the cause of Bpsd. Okay, after you manipulate the environment for the patient, you have tried that. Okay, and that fails after you after you train, you communicate, you train the caregiver, you communicate, you train your staff, it still fails. And also after, for those in long-term care, after those resident factors which can modify have been evaluated and it's still, the patient still has Bpsd, then it is justified for you to use your antipsychotics because it causes a danger to the person and to the others as well. But if you need to use again individualized initiate monotherapy, titrate the dose, continue a few weeks or a few months, and then try to stop the drug. Okay, if it's not effective, then stop earlier. Even if it's effective, then you need to taper it down. Okay, this is just a reminder for all the Ministry of Health staff. Actually, we do take informed consent, at least in my previous department. We do take informed consent, and we find that if we take informed consent, we are forced to educate the caregiver about the side effects of antipsychotics, right? And you find that there is less agreement by the caregiver to continue with the use of antipsychotics. Okay, so if you want to use, then use atypical antipsychotics, okay, rather than typical antipsychotics. Okay, so this again is just a reminder for you, right? So always bear in mind that good practice is clear, okay, but it's very much the exception rather than you know, others. Okay, so analyze the behavior. Watchful waiting, because 50% of the Bpsd are self-limiting, right? But where medication need to be used, then these are the things that you need to consider. It's a shared decision. So always discuss with the relatives, okay? Use atypicals at the shortest possible time. And once initiated, your continuation should be reviewed regularly. Okay, how long should we use? So what is meant by short term? Okay, older age, male gender, severe dementia, and functional impairment. Remember that there's a higher risk of death in the first 30 days of usage of antipsychotics. And this can last up to 2 years of treatment, right? What the guideline and nice quality standard on dementia is that if you need to use, you need to review at 6 and at least at 12 weeks of treatment, okay, and discontinue treatment unless there is persistence of severe symptoms. Australia and New Zealand guideline also says antipsychotic should not be used longer than 3 months, and Malaysian CPG does not give any definite time. That's the CPG in 2009. We have to wait for the new CPG, which will be coming out soon. And you need to review at least 3 months. Okay, again, this is important to remind the doctors who are managing this patient. There's actually no role for PRN antipsychotic medication in people with dementia. So if you need to use it on a regular basis. Okay, which antipsychotics to use? Okay, 4 different groups of antipsychotics have been studied. Your aripiprazole, olanzapine, quetiapine, risperidone. I have given you the high evidence, the evidence on the left side, the table on the left side. which has low evidence, which has high evidence, and so on. Okay, a meta-analysis does show that there are benefits for risperidone, aripiprazole, and olanzapine, but quetiapine failed to show any statistically significant benefits. So it's not really recommended for routine use, okay? Plus, it has the highest anticholinergic properties as well, okay? Risperidone is effective in reducing agitation compared to placebo. Okay, similarly, aripiprazole as well, because it does show improved outcomes on your NPI. But again, okay, get it into your mind. Remember of the risk of using all these antipsychotics. So the table below, I just outlined to you the relative risk of mortality for patients with Bpsd in dementia. Okay, the highest is with the use of haloperidol, and the least is quetiapine is still here. Okay, the least is the olanzapine, quetiapine, if you need to use, that is. Okay, as for antidepressants, it is used quite frequently in depression in dementia, but we do use sometimes to control irritability, agitation, and aggression because this can be part of the depression in people with dementia. But data are very much lacking to support the use of antidepressant for this indication, okay, despite of it being used quite widely in clinical practice. Okay, only 3 antidepressants have shown some promise: citalopram, as well as other types of SSRI, trazodone, and mirtazapine. But if you need to use citalopram, remember that there is an FDA warning to limit the use of citalopram to less than 20 milligrams in persons more than 60 years of age, because it can cause an increase in the QTc interval. Okay, this holds true for people with dementia, older people with dementia as well. For trazodone, anecdotally, it's been reported to be effective, but there is insufficient RCT data on your Cochrane review. Okay, so again, which antidepressant? Okay, there's low quality evidence that sertraline did have some improvement in Bpsd, actually, right? And it's a class reduced. Ptsd is people with stroke in dementia, people with stroke in dementia who develop agitation. Improves actually compared to those on placebo, but the latest NICE guideline in 2018 actually do not recommend to offer antidepressants in mild to moderate depression for people with dementia who has mild to moderate disease, unless they already have a pre-existing severe mental health problem, pre-existing depression. So in conclusion, Bpsd are common. It does cause significant distress among patients and caregivers. The cause is often multifactorial. These are the steps that you need to take when you manage a person with Bpsd. Conduct a risk analysis, address the imminent safety issue, explore, identify, and address the following potential contributors, prescribe judiciously, and clearly you need to document every step of the way. So again, in conclusion, remember, non-pharmacological treatment is still the first line of management with Bpsd, with or without drug therapy. Okay, antipsychotic medication, if you need to use, bear in mind that it can cause an increased risk of death and CVA. So it's a good practice to do a full risk-benefit profile with consent when prescribing. Okay, so with that, I'll end my presentation. Okay.